Thank you for your attention. I am Dr. Paul Zai. I'm from the US in Boston, Massachusetts. This is me. These are my disclosures. And I've been talking about zero fluoroscopy or fluoroscopy reduction for many years now, as some of you know. And I think this is a very good opportunity to go over some of the ideas because it's a new era now. But to start with, of course, we understand now catheter ablation for AF has become a mainstay of our therapies. And I just highlight in the most recent US and European guidelines that this is now a first-line recommendation for many indications. So there's a lot of AFib ablation going on, and the patients are becoming younger, and it's only going to increase over the years. And part of this is because there's been many years of work that has led to this. As a culmination, perhaps, our registry data that we published last year shows a high 1-year freedom from AF if you use state-of-the-art, but this is with radio frequency, and this is because we have evolved technologies, the techniques that we use during procedures. However, of course, we understand that with RF, there's still some limitations. We worry about risks, as we all know, of things like phrenic injury, PV stenosis, atrial esophageal fistula, and we want the procedures to be shorter. So why the zero fluoroscopy question? So you all recall the principle of ALERA, which is as low as reasonably achievable. So if we can achieve the lowest amount of radiation safely and effectively, we should be obliged to do so. And that's the principle behind this. And that's because quickly, for the patient, there are many risks. There are risks of skin injury, there are risks of radiation exposure, and that sort of thing. And also for physicians, there are risks of orthopedic injuries and potentially, at least, malignancy risks. On top of that, fluoroscopy doesn't tell us very much. It tells us catheters and it tells us some shadows, but it doesn't tell us relationships to tissues. It doesn't tell us tissue contact, that sort of thing. And it only is active when we push on the pedal. So over many years, I think many people have worked on moving towards less and less radiation, and I think the technology has allowed this to happen with mapping and ice, as you see here, has been the mainstay. So over these years, just to highlight in a timeline, if you start all the way back to where ICE was first introduced in the 1980s, through mapping systems in the 1990s, and then more and more use of more advanced mapping and ICE techniques, we've developed the idea of zero fluoroscopy. Now we're in a new era, of course, because in the last several years, PFA has really taken over our field. So how do we get from here to there? So before we dive into that, though, there is now growing evidence in the literature. So this is just a very recent search I did on PubMed, and you can see that there's still an increase in articles looking at zero fluoroscopy ablation. So there's much more literature that is sort of confirming safety and efficacy, at least specifically for RF and cryo. So now we get to PFA. So of course, this is a disrupting force in many ways. So of course, because of the safety profile, the speed, there's been very rapid adoption of PFA, first in Europe, then US, and now throughout the world, including of course here in China. There's ample data now. This is just a very small, as you know, sample of the data available looking at outcomes now gathering for PFA. And you can see the outcomes are generally, I would say, efficacy comparable to RF. And of course, we know the safety is very good. So we're at a state nowadays where there's a very rapidly changing world. This is just, I have to update this slide every few weeks or now almost, where there's new approved data and new approved devices. I focus specifically on US and EU because that's what I'm most familiar with. But of course, as you can see on the bottom, there are multiple companies here in China that are also developing various catheters with various features that I've shown here. So there's a large selection, basically. Oop, wrong way. When it comes to zero fluoroscopy, however, if you look at the most recent data, we've taken a step backwards. So if you look at our registry, the real AF data, 71% of the data in experienced users use zero fluoroscopy, and the rest that used had an average of 1.74 minutes of fluoroscopy. However, you look at three of the maybe most well-cited PFA studies, Manifest, Advent, and Pulsed AF, they range from 12 minutes up to 26 minutes on average of fluoro. Of course, granted, these are early adoption and early studies, so they're almost certainly decreased, and I'll even show you some of our data that confirms this, but it's a step backwards. And that there's several reasons for this. So not only is it these are new catheters to learn, but they're often over-the-wire systems, which are harder to use in an ICE system, and they were still a little slower step to adopt into a mapping system as well. And specifically in Europe, there's very limited use of ICE, and so they have to rely much more on fluoroscopy. So when we start thinking about this for PFA, I think you always have to weigh risks and benefits or pluses and minuses. So the factors I think that favor zero fluoroscopy are going back to the Alera principle of low radiation. And if you can demonstrate good safety, I think that's also a benefit. But of course, you can imagine there's questions of cost, and is it going to make the procedure longer? So maybe one way to frame this is to look at the typical workflow one would employ for whether it's RF cryo, can you apply to PFA? So I think again on the left you need this kind of equipment, of course, an ICE and mapping system, of course, an ablation system, and of course, something for your transeptal puncture. Now, it's not clear you really need some of these other options like a high-density mapping catheter, but either way, the workflow is almost identical for all of these strategies. Of course, you have your access ICE placement, whether you map the area or not, you then perform transeptal, left atrial mapping, ablation, and validation. So that's all the same, but there are perhaps some differences when it comes to a PFA workflow, and I'm going to go over some of those. So first and most important, in my opinion, is that not all mapping systems that you might use are created equally. So catheter visualization, especially contact, varies from one system to the next. And what that results in my opinion, at least at this stage, is that we have to be even more facile with ICE. So that's allowing for things like tissue contact and to visualize some of these one-shot catheters, which are a little harder or different to manipulate than, I would say not harder, but just different than a point-by-point catheter. And visualizing those catheters on the mapping system are a little bit more challenging. And again, I mentioned earlier, the wire-based catheter designs can be more challenging to visualize on a mapping system. Specifically, getting into a little bit more of the details of what you need to be focused on when you're using ICE for the PFA workflow, you have to be able to see that catheter, to see the sheath, to ensure tissue contact, and see the wire ideally, visualize the contact with especially when you're in the antrum and ostium of the veins, and then of course in other sites that you might be targeting for ablation. Here's just an skipped ahead. This should be playing. Let's see. Well, if it doesn't play it, you can see the pictures anyway, but this is one example. This is actually with a Farapulse catheter. If you have, even from the right atrium, adequate or even good ICE views, you should be able to, as you see, I've shown examples for each of the PVs, very clear visualization of tissue contact with the catheter, whether it's in this case in a flower or basket position, with the result being a good ablation outcome, as you can see in the middle, at least acutely. So what I want to spend the last couple of minutes talking about is there actually starting to be evidence for these this idea of using zero fluoroscopy ablation. So we have some data specifically that we've published or are going to publish for two specific systems, the Boston Scientific Farapulse and the Biosense VariPulse. So with the VariPulse, this is just recently published in Europace. If you recall, the US ID study called ADMIRE was about 150 or so patient study looking at the varipulse catheter, first use in the United States, and as a prospective multicenter single-arm study. What we did was to take that study and to perform a sub-analysis, and we looked at patients that we divided into what we called zero fluoroscopy, so zero use of fluoroscopy, obviously, what we defined as low fluoroscopy, under 5 minutes, and conventional fluoroscopy. Dr. Wozni was a participant in this, of course, as well. So what we concluded is shown in the central illustration on the left, which is that and then also on the outcomes on the right for efficacy at 1 year, is that whether you use little, zero, or a fair amount of fluoroscopy, the outcomes are not changed. So you do not degrade in your efficacy. But then if you look at the trends towards safety, which is shown, let's see if I can, which is shown in the middle column here, it's not significant because of the lower numbers, but there actually is a trend towards lower complications with less fluoroscopy. Now, you might ask, why is that? My hypothesis is that these groups tended to use ice much more throughout the case, and perhaps that improves safety. I don't know, but I don't think it's the using of less fluoro, stepping on the pedal less. I think it's using ice more is my hypothesis. Anyhow, so then, as you might be familiar, we're also running several registries in the United States, what we call real-world evidence registries. First, something called Real AF, which is a J&J sponsored registry, and then a second one called Disrupt AF, which is a Boston Scientific sponsored registries. These are multi-center, about 50-plus centers each, thousands of patients now under enrollment. We've adopted both of these for PFA platforms, and so we are actively enrolling patients, and we'll be looking at outcomes from these. So just as a very early, because we're still working on the outcomes, or look at our Disrupt outcomes that we've submitted for publication. So first thing, if you look at varipulse, especially in early adoption before we had a dedicated mapping system and early on, if you look at fluoroscopy use over time, you can see this chart, the scatter plot here, from the first to the more current cases that operators are doing. There's a natural learning curve where fluoroscopy use becomes less and less over time, to where many cases now, and I'll say roughly about 40% of our cases are done now in varipulse with zero fluoroscopy. So it's a natural learning curve for skilled and experienced operators, I think. Now, for the Real AF registry for varipulse, because the release in the U.S. was a little bit later, this is still a work in progress. So we have currently about 500 patients enrolled, and the zero fluoroscopy use is in the range of about 70%. So again, very much feasible. We will be hopefully publishing this data soon. So to summarize my presentation, so the technological advances in ICE and mapping have enabled zero fluoroscopy ablation, and mainly until recently for RF, of course, but now for PFA, I do think that this should be part of a standard, at least approach towards a goal of less and less fluoroscopy. It's safer for you, safer for the patient, and as we've demonstrated now in early results, the efficacy is not diminished, and the safety may be better if you are using ICE more frequently, and this will all improve, of course, as the technology improves over time. So I'd like to end my presentation here, and thank you so much for your time and attention.